of COVID-19 on the mental health of Indian population. First, we analyzed the direct impact that the outbreak of COVID-19 was having on the psychology of the population. And the other thing that we did is we analyzed the impacts of COVID-19, such as the quarantine and isolation and all the hygiene practices that were employed, etc., etc. Through that, we identified the following factors that were having a detrimental effect on the mental health of the population. Most important of them was, of course, the risk of getting infected. Secondly, the unforeseen complications of the disease. Third, the anticipation of detrimental long-term effects. Then the uncertainty of disease progression, and the lack of standardized treatment guidelines, and the overall unpreparedness of the infrastructure and health system. On the basis of that, we read a few research papers, and one of the recent studies that were done in India showed that about 71.8% of the participants were worried, 37.1% were irritable, 24.7% were depressed, 33.1% were suffering from sleep alterations, and 57.8% were worried about their future, and 69.6% were worried about their financial losses, were worried about financial losses that they will be incurring in the future. Most of the participants perceived an alteration in mental status and was showing increasing need for personal help. This results were of significantly higher percentage in comparison to community samples prior to the pandemic. Then we moved on to the mental health of the healthcare workers. We realized that the following factors, that is the increased workload, threats of assault and eviction. A lot of Indian doctors were forced out of their residence because of the stigma surrounding COVID-19. Then there was pain of separation from family. There was they had inadequate supply of personal protective equipment and hospital equipment. Finally, we came to the impact of the interventions that were used against COVID-19 on the mental health of the population. The following mitigation strategies contributed heavily to the psychosocial adversities, such as case identification, contact tracing, social distancing, and quarantine and isolation. There are some studies that have shown in the past that mass quarantine and lockdown can cause increased irritability, mass hysteria, anger, confusion, frustration, loneliness, denial, anxiety, depression, insomnia, and despair, leading to PTSD and suicide in extreme cases. Another thing that we came across was the impact of the public health interventions that were used against COVID-19 on specific vulnerable groups, such as the elderly, who were socially withdrawn. They suffer from fear, anxiety, irritability, and emotional liability. Then women and children, because of the forced prolonged proximity with family, had stressed relationships, and resulting in domestic abuse and violence. Children, due to home confinement and lack of in-person contact with peers and teachers, became more irritable. Patients with pre-existing mental disorders had even worse outcomes, and they basically lacked access to immediate mental health care services. And obviously the migrant and daily wage workers, because of loss of livelihood and loss of income, the kind of there is great evidence that low socioeconomic conditions contribute heavily to psychological adversities. After studying the direct impact of COVID-19 on the mental health of the general population, we decided to, through extensive review of policies and research papers, we decided to identify the gaps that are present in our health systems and our policies. As far as finances were concerned, we found out through multiple calculations that there is a deficit of 940 uh, 94330 million rupees, about 12,600 million, which is about 12,600 million USD in the government's mental health expenditure program, in the government's mental health expenditure, which ended up provoking a treatment gap of 70 to 92%. According to the Mental Health Atlas of 2017, India's per capita mental health expenditure stands at about 4 INR, which is less than 0.50 USD, with a majority of people paying mostly and entirely out of their pockets. The Pradhan Mantri Jan Arogya Yojana, which was meant for coverage of mental health, includes only 7 packages for treatment of organic disorders, schizophrenia, schizotypical and delusional neurotic disorders, stress-related and somatoform disorders, mood affective disorders, mental and behavioral disorders due to psychoactive substance abuse. We also identified that these mental health service packages are currently available only in 0.7% of the empaneled hospitals, which is only about 2,500 of the institutes from about 21,000 institutes, and which made them geographically very skewed and limited. That was, apart from that, we realized that we have a critical shortage of workforce, mental health workforce, with merely 1.93 mental health workers per 1 lakh people. The National Mental Health Policy and the Mental Health Act, which were basically introduced to provide equitable and just coverage of mental health care needs in India, have very limited provision for the acute increase in mental health needs during a pandemic. So on the basis of all this information that we analyzed, we came up with 10 policy solutions. And here on, I'm going to give you a brief on these 10 solutions that we came up with. So firstly, we started by calculating the deficit in the finances that are subjected towards mental health care. Currently, we require an influx of 9,40,730 million Indian rupees, which is about 12,600 million US dollars. This will help us to reduce out-of-pocket expenditure. It will also help us increase the number of empaneled institutes in PMJ. Thirdly, it'll help us increase inpatient psychiatric beds. And finally, as far as long-term outpatient needs are concerned, it will also cover follow-up treatments. Studies have shown that the estimate loss incurred by the government for non-investment on mental health is 6.5 times more than the investment needed to implement MHCA 2017 every year. Our second solution to mitigate the deficit in mental health care workers, in order to achieve a target of around 3 mental health care workers per 1 lakh Indian per 1 lakh population, India would need an additional 30,000 psychiatrists, 37,000 psychiatric nurses, and 38,000 psychiatric social workers. This unmet need demands an increasing psychiatric specialization seat for MBBS graduates. The cost of training one psychiatrist is about 10 million Indian rupees, which is about 0.1 million USD. Finally, it would also help if we can provide short courses for other healthcare workers like the nurses, paramedics, ASHAs, ANMs, etc. Then we moved on to merging of emergency and mental health policy in legislations. In Ireland, the Emergency Measures in the Public Interest Act 2020 was passed as early as 27th March for the provisions relating to mental health during the pandemic. However, India does not have any such legislative structures as yet. Laws directing disaster management and response plans should be adopted under the MHCA 2017 and National Mental Health Program to account for COVID-19, to include the component of care of mental health. Governments must also ensure a whole of society approach to promote and protect mental health of the people during public health emergencies. One of the most crucial solutions that could help mitigate the mental health crisis post the COVID-19 pandemic is implementing peer-led task shifting initiatives. Task shifting initiatives from specialists and physicians to non-specialist mental health providers and informal community care providers could be developed to improve mental health service provision. Social networks can be revived and participation in community activities could be increased as a part of treatment and care for patients with depression, anxiety, and psychosis. Previous RCT's results have depicted significant clinical efficiency for improving psychiatric, social outcomes, and high cost effectiveness of intervention packages such as psychoeducation, case management, interpersonal psychotherapy, and antidepressant delivered by lay health workers. Moving on, we believe that strengthening telepsychiatry services in rural regions will help deliver mental health care in a more effective manner. The evidence on the cost effectiveness of telepsychiatry is quite positive, as most studies demonstrate that telepsychiatry reduces direct and indirect costs and increases quality of life, life-adjusted years when compared to face-to-face consultations. There's a recent retrospective study, I think it was conducted in Kerala, which suggested that the cost of telepsychiatry services was less expensive than clinic visits and home visits by psychiatry teams. There was an increased access to healthcare, faster treatment, and it also reduced waiting and consultation time. Meanwhile, it also increased medication adherence. However, with India having 657 million internet users, internet penetration of 50%, half of the population is yet to receive access and quality telemedicine services from the convenience of their home. So we believe equipping gram panchayats with internet facility and enabling access to telemedicine through this might prove to be a rapid and cost-effective measure to counter the problems of reduced accessibility. We also believe that employing psychosocial interventions can help reduce the burden on psychiatric institutes. There was an umbrella review of which suggested that psychosocial interventions such as non-pharmacological or physical interventions comprising structured psychotherapies like CBTs, social skills training, exercise, and art therapy have a clinically relevant effect on improving social functioning. Both adults and children with conduct disorder and PTSD benefited from using psychosocial interventions. The Manashanti Sudhar Shodh project involved training lay health workers to provide psychosocial interventions as part of primary care, and it was found to be cost effective. It also overcame barriers posed by shortage of mental health professionals. This approach could be crucial in ensuring that such interventions are sustainable, ethical, and meet the drastic surge for mental health care in the wake of the pandemic. So children were one of the highly affected groups as far as mental health was concerned. So we believed in integrating school-based psychosocial interventions is essential. Evidence-based, universal, school-based socio-emotional learning programs should be aggressively scaled up to improve social and emotional functioning and academic performance. Um, as per WHO choice, the SEL implementation costs only less than 0.10 USD per person a year, with an average cost effectiveness ratio of 1,000 to 5,000 LMICs. It is important to implement targeted health education, such as psychoeducation, about normative reactions and coping strategies that integrate disease prevention and control in daily activities and lessons, while ensuring that the content is age, gender, ethnicity, and disability responsive, and the activities are built into existing subjects. By yeah, finally, we believe that building public awareness through social media is essential because mental health awareness through information, education, and communication can promote mental well-being, and it can aid prevention of mental illnesses. It can also be instrumental in reducing prejudice. It is very important to inform the public about the common stress response with the general guidelines on countering stress, such as sleep hygiene, activity scheduling, exercising, social connections, avoiding social medias, uh, and relaxation and using relaxation techniques. Uh, it is essential to involve the community in management of mental health program and promotion of mental health through collaboration at local level with civil societies and organizations such as women's self-help groups, village health and sanitation and nutrition committees, and resident welfare societies. Misinformation and COVID infodemic have been one of the major factors disrupting mental health throughout the world. The government has been battling a deluge of disinformation, making it difficult for people to disambiguate the truth from falsehood. Unlike countries like France, India currently does not have a law dedicated to fighting the spread of misinformation. So, apart from the legislations that are needed to tackle the root of the problem, creating helplines and forums for fact-checking informations can help curtail the spread of misinformation. One such example that you can check out is the WhatsApp Coronavirus Information Hub that was developed by the UN Development Program, WHO, UNICEF, and International Fact-Checking Network. Finally, it's important to reduce stigma for general mental illnesses. Recurrent themes surrounding stigmatization, portrayals of mental illness, and ECTs in the media hinder health-seeking behavior, and there are currently no laws in India that can direct or censor the distorted portrayal of portrayal of mental illness in the media. So in the long term, it's important to have scientific and informed depictions to promote destigmatization among the larger masses. For instance, the Australian Stigma Watch program has been very effective in curbing the inaccurate media reporting depiction of depression and mental health issues in general. There was a meta-analysis of public stigma reduction interventions, which included educational programs that showed a decrease in stigma related to mental illnesses. So moving on, I was actually there was a presentation that I saw which was made by Surbi, and she had certain limitations mentioned in it. But I spent a lot of time thinking on the kind of limitations that our presentation has, but I couldn't come up with something concrete. So she told me that maybe people who are listening to your presentation can come up with some suggestions that could be included in the limitations of this paper.
Avanti, it would be helpful if you went over your methods once, like what exactly did you all do? Like how was the review conducted?
Okay, so just yeah, I think I think Siddesh will be able to explain this better, because although I know what we did, I don't think I'll be able to,
Siddesh, would you like to chip
explain
in?
it in a good
Yeah.
manner. If that's okay with him, actually.
Yeah, of course. I thought you were able to see me, but looks like you're not.
No, like I know what we did, but I don't know if I can
Yeah.
explain it to others.
Yeah, that's okay. So to begin with, like Avanti explained really well, the idea of this paper was to look at what kind of policy responses is India generating for the psychosocial uh, pandemic, kind of pandemic actually, psychosocial pandemic that has been going on along with COVID, right? And typically in these kinds of policy assessments or reviews, the idea is not to bring out all the available evidence, but to kind of rank and grade uh, the evidence and then bring only that out which might be most feasible for implementation. So with respect to that, we use the typical methods, which is to begin with the review of existing policy documents. So these are usually things like national plan, state plan, or bigger national surveys. So in India's case, these are surveys conducted by NIMHANS, which is the Apex Mental Health Research Organization in India. Apart from those, we also work through the WHO documents. WHO has been releasing several guidelines, also several assessments of how different countries could do better or might be responding to the pandemic. So we use those. And finally, we mostly looked at meta-analysis of RCTs when it came to looking at what interventions could be effectively scaled up. Uh, so these are mostly Cochrane reviews, which try to pool data from different lower and middle income countries. And then we were trying to isolate data for India from those and say which things, like Avanti explained. So for instance, something like peer-led psychosocial intervention is something which has been tried out in India. It has been shown to be effective and cost effective. So this is something which could be scaled up in a relatively short time. Does that help, Survey?
Yeah, but I think like including me, a lot of people are not really aware of this sort of methodology, right? So
Yeah.
then like, do you have like a time frame when you do a policy review, or like what exactly is the search strategy that's followed?
Yeah. So I mean, usually a couple of things would be uh, kind of made mandatory in terms of what you should and shouldn't include. So one thing is that you usually do not include uh, kind of lower level evidence which comes from individual studies, right? So that's something which we were trying to avoid. However, in this case, uh, given that we are looking at something which is ongoing, a lot of COVID research hasn't been analyzed at much higher level yet. So I think there is that in such kind of policy reviews, you'll usually find like the scientific or research evidence that is being cited is usually at the level of bigger systematic reviews, bigger meta-analysis, and things like that. So that's first thing. Second is we, uh, given the urgency of the matter, we avoided going too much into the history of some of these individual components. So, for instance, in terms of looking at or reviewing the national mental health policy documents. There have been earlier versions of those documents, but we chose to go for the latest one.
Okay, so what time frame did you all follow approximately
In the sense of,
for the mental health policies?
yeah, so everything that has been there after, I would say, 2015, 2014, 2015.
So then I think you all can tell us your limitations based on that.
Yeah, I think initially when we started writing this paper, there wasn't enough research present. So there wasn't enough data to work on. But eventually, in the past 2-3 months, yeah, but it hasn't been very quality data. I mean, to base a policy review on is what I feel and what I've learned. Maybe
Okay.
this is what I think our limitation was.
Yeah, I think, yeah, I agree. Our biggest limitation right now is that a lot of COVID data that we are citing is its its reliability is kind of questionable, and that's probably the case with all other COVID policy reviews coming up as well. So, like, what we are trying to do is put forward the best we have, but with an understanding that it's not the gold standard that usually is considered in science or research.
Surbhi, can I add on? This is Nalita
Yeah,
here.
definitely.
Yeah, and I think one other issue that we faced when we were trying to, find or provide solutions to some of the problems we identified was that a lot of solutions that we were citing from meta-analysis, like with respect to efficacy and how effective they were at a ground level, they were all Western data, and to try to like extrapolate that into a Indian setting, like for example awareness strategies and education models and things like that, or like breaking stigma, things like that, which has a more intrinsic like they have a socio-cultural background to it, so you can't really like extend that data from one country to another. Things like that I think we found difficulty because we couldn't cite more relevant data for problems like that.
Right. So you're saying not a lot of data was available for India.
Yeah.
Does anybody want to add on to that? Does anybody have any questions?
Well, before we do that, let's congratulate Avanti for giving
Yes,
this presentation, and then we can
definitely.
open it for any kind of Q&A.
I think I
Yes.
So
bombed, but
it
that's
could be
fine.
you can cut off your mute and clap, or show us your support in the reactions wala button. I'm going to do both.
Yay.
Okay, guys, stop embarrassing me.
No, this was Avanti's, I think, first paper and first presentation, so she's done a great job with it.
Okay, thanks. Thank you so much. I hope that I improve in the future.
Like the meeting is about to end in a minute. I think you all can use the same link to join again, right?
Okay, yeah.
It'll end any minute.
Can you?
I think you can, yeah. You can use the same
Okay.
link to join again. Once it ends. After that, then we can move on to the questions.
Yep.
Okay, yeah.